Welcome back to Plastic Surgery Decoded, the podcast designed to help you better understand plastic surgery. We take the mystery out of it in plain language. You'll find it interesting and useful whether you are already planning a procedure or you're just curious. I'm your host, Dr. Regina Nouhan, and we are now into Season 5 of the podcast. After you listen to this episode, know that you can explore and enjoy many other topics, either through your favorite podcast app or through the website at plasticsurgerydecoded.com. The first 40 episodes, or Seasons 1, 2, and 3, comprise the Plastic Surgery Decoded Classics, with my singular voice covering cosmetic and reconstructive procedures, skincare, and general questions about plastic surgery. The remainder of episodes, Seasons 4 and 5, are interviews with my colleagues around the country to help you learn about the subject. A great variety to choose from. Remember that this podcast reflects my experience and opinion, as well as those of any guest interviewed. It is not intended to provide medical advice, nor is it a substitute for a formal consultation with your physician. So come along with me as we explore this ever-growing world of plastic surgery. Let's go! Over time, most of us notice changes in our face related to gradual aging, but may be interpreted by others as looking tired, not youthful, or even depressed. So it's not a matter of aging gracefully, it's a matter of not looking like we really feel. Now, I'm sure I don't have to tell you what a plethora of therapeutic options are available these days, aimed at rejuvenating the face and reconnecting the person inside with their appearance on the outside. Yet, given the anatomical nature of how we age, the various areas or layers of the face may each see benefit from a different type of treatment, ideally suited for it. One size does not fit all in the facial rejuvenation world. So what about combining procedures and treatments for the face? It makes logical sense, but what is the best way to approach that concept, and how safe is it? Today we have in conversation Dr. Surek, who helps answer these questions and leaves listeners with some great take-home information to utilize as they consider their own options. Take a listen. Well, I'd like to welcome today Dr. Surek, who is a plastic surgeon practicing in the Kansas City region, and he did his plastic surgery training in Kansas City, and then additional training in the form of a cosmetic fellowship at the Cleveland Clinic, focusing on the face. Now, he has, at a young age, taught deep plane facelifting all over the world, including Dubai, Canada, and even South America. And he is currently the chair of a deep plane facelift and neck lift cadaver lab and teaching course at the annual aesthetic surgery meeting. And actually, the most recent meeting just concluded in Austin. Welcome, Dr. Surek.
Regina, thanks for having me. Honored to be here.
You are so welcome. I would love for you to first just start out by telling the listeners about your plastic surgery practice. What types of patients do you see or cases do you do typically?
Absolutely. So I'm based in Overland Park, which is a southern suburb of Kansas City. Mm-hmm. I'm a Denver native, but I came here 20 years ago for med school and met my wife, and the rest is history.
Uh-huh.
I am in private practice, Surek Plastic Surgery, and I'm almost exclusively cosmetic. So I do a small amount of facial reconstruction after skin cancer, but I'm primarily all cosmetic surgery. My most common operation, as you mentioned, is facelift, eyelids, and ancillary procedures of the such, like deep chemical peeling and injectables. But I still do a decent amount of body contouring, breast aug, breast lift, tummy tuck, 360 liposuction, kind of the mommy makeover. As a matter of fact, I do a lot of both on some of my patients, both body contouring and facial sculpting. So that's my primary practice setup.
I think that's an excellent point because there may be a temptation to really specialize in one area and just the face, but many of your patients are going to perhaps want more than just that, and it's nice that you can offer full service, so to speak. Well, we're here to talk about the concept of combining treatment types in facial rejuvenation. And as we delve into that topic, let's first ask, what are the goals for rejuvenating the face? What specifically are we trying to accomplish when we say we're rejuvenating the face?
That's a great question. You know, it begins and ends with anatomy. Anatomy was my first love. I did a fellowship in anatomy while I was in medical school. And immediately I realized when I got into practice that everything I do day in and day out is treating anatomy. Every crease, crevice, shadow, contour in the face can be traced back to some anatomical structure. And the good news is anatomy primarily is predictable, as is facial aging. So although we all age, we age in a predictable fashion, which makes it predictable to treat. And oftentimes that means combining modalities. And I believe there's two types of aging. There's chronological age, in other words, how old you are, and anatomical age. And the reality is some people can be 50 and look like they're 60, or be 60 and look like they're 50. So I primarily rely on anatomical age to determine what my patients need, and then I build a treatment plan off of that. But it's
That's great.
anatomical aging is really the goal.
Okay. And as we talk about anatomical aging, when you are evaluating a face and you're assessing the anatomical age process that has occurred and the things you might do to intervene, what specifically are you looking at to try to treat? Is it the tightness of the skin or the smoothness or the volume underneath the skin? What are you looking at and what are we trying to improve on that patient?
I think you divide into two components. You have the skin and then everything else below the skin, kind of like the pillow and pillowcase analogy.
Nice.
So if we talk about what's below the skin, you have a bony architecture, you have fat, deep fat, and then subcutaneous fat. And then you have the facial muscles and the bed sheet that wraps around them called the SMAS layer. We know that we have bony resorption, meaning that we lose skeletal support as we age. So that's one. We know that we also lose volume in our fat pads. So a lot of times if someone comes in, the first thing I talk to them about, especially if they're, let's call it mid-30s, is how do we keep up with the volume loss, right? You're losing volume in your fat pads. We need to catch you back up.
You're saying that even patients in their 30s are losing volume, losing fat that helps keep them youthful.
Absolutely. It's a fact that as we age, very slowly, we lose volume in the deep fat, which supports a lot of structures, the cheek, the jawline, the chin, the nasolabial fold, the temple. All these areas we're experiencing volume loss. And yeah, if you start to look at people critically, oftentimes they might have a little groove along their cheek or a little shadow between their chin and their jowl, and that's a reflection of volume loss. And if caught early, 1 or 2 cc's of filler and you catch them right back up. One of my favorite things to do is when I inject filler in someone like that, for example, so if they're not ready for surgery, they're at a volume loss state, but not a gravitational change state. Then if I see a little groove in the cheek, I'll inject one side and pop that cheek out to a nice youthful look, and I'll do what's called a halftime show. And I'll pull the mirror in front of them and say, hey, look what we can do with just 1 cc of filler. And it's a beautiful way to demonstrate to the patients how you're precisely treating the problem that is occurring at that point in time in their life.
I bet they love that.
It's fun.
Yeah. Well, that's a great description of what's happening underneath the skin. What about the skin itself? What is changing? What are we trying to improve? And again, not necessarily treatments yet, but what are we trying to make better?
Very good. So when you think about the skin has multiple layers itself. But the things that we see start to show themselves with age is the skin slowly thins, right? So we lose collagen, which is the framework, structural support. So the skin thins. We also notice it becomes lax. So we see gentle wrinkles develop and what are called rhytids. And so we start to see the texture of the skin not be as smooth. It's more coarse. It's rough. It's sometimes scaly, almost leathery appearing. And then lastly, there's pigment. And, a majority of people have some sun exposure, especially some generations where sunscreen wasn't even a thing, where now we get expression of pigment that creates these spots scattered about our face, and that can change our complexion and make it irregular. And so when I look at skin treatments, I'm looking for something that can strengthen or thicken the dermis or the architecture of the skin, that can resurface or clean off that layer of rough wrinkles, and then also lighten pigment so that I can regularize or even their complexion.
Yeah, that's wonderful, and that's what people want. And I would imagine as they come in for consultation, they may be focused on one particular aspect of all those things you talked about. but perhaps there's more than one issue going on, and sometimes I would imagine you can help them see that. Well, as our listeners know, there are just so many options for facial rejuvenation these days. Would you please go over some of the different categories for intervention on the face? What is out there, and what is that particular category best at treating?
That's a great question. I honestly think right now it's a very hard time to be a patient or a consumer in the aesthetic world, because with social media and online platforms, everyone has a voice, even those who sometimes may not be giving the best advice, right? Or may have ulterior motives as far as their own financial growth or personal growth. And so I take that very seriously. And education to me is critical. An educated patient tends to be a compliant and dedicated patient, and hopefully a happy patient in the end. Simply put, you divide into two categories, surgical and non-surgical. And I think we're going to broach upon surgical later on today. But the non-surgical realm has grown immensely, even since I've gotten out of training. I mean, over the past decade, we've seen significant advances, a lot of momentum, and even impulsivity when it comes to devices and it comes to lotions and potions and creams and all the things you can treat. So non-surgically, I look at three components: skin care, non-surgical devices, which includes resurfacing, which could be peels, and lastly, volume replacement. So when it comes to skincare is very challenging. I have patients who come into my practice. My practice is designed to where I don't make money off of skincare products, or not very much. So I'm not motivated to sell people stuff they don't need.
Yeah,
And
that's great.
skincare can be a black hole, right? I've had patients come in for facelift consults who are on 6 products in the morning, 6 products at night, spending over $1,000 a month.
Oh my gosh.
And when I look at those products, none of them have active ingredient in it.
Just moisturizers, basically.
Yes. And they're trying to take care of their skin, but they're not using the proper stuff because they have not been properly educated. So when it comes to skincare, there's 3 key things that I think the audience should know. You need a pigment corrector. You need an antioxidant to neutralize free radicals. Remember, the skin's a living organ. It excretes waste. We need to neutralize those free radicals. And then we need a collagen correction agent, something that's going to help re-strengthen, restructure, support our dermal, which is our deep layer of the skin. And on top of that, we need sun protection. Beyond that, the rest of the things may be important for you, but that has to be specific to you and your type of skin. So I always keep it with the simple ABCs: antioxidants, barrier, and correction, both collagen and pigment. And that's where I live in the skincare realm. Then you can springboard from there to devices, both lasers, for example, or deep chemical peeling, or even moderate to mild chemical peeling. And all those relate to penetrating a particular area of the skin, resurfacing or softening sunspots, fine lines, redness, for example, vascular pigment. All these things can be handled by those. And I think they have a great role. Some are better than others. And I think it's important to do your research and really make sure you consult with somebody who you trust, who's authentic in their delivery and understanding, and has made a clear point to you how these products can really help you in these devices. And then lastly, the injectable realm. And injectables have really gained a lot of popularity.
Oh, yes.
Particularly the dissolving, right? The ones that are non-permanent, which is primarily hyaluronic acid fillers. There are a couple others out there: calcium hydroxyapatite, biostimulators as well, that create a fibroblast response and can adjust or enhance skin quality and collagen. And now even permanent fillers, which include a variety of products, as well as autologous fat, which is often an adjunct to surgical operations. I do believe that fillers play a role, especially, as I mentioned, in that kind of in-between period where patients are starting to see facial aging, but they're not seeing the gravitational change that would warrant an operation.
Yes.
But again, I think fillers should be treated carefully, tastefully. The overfilled face is a concern. And again, that's just a byproduct of someone having too much product and probably a little bit too much treatment than needed. And so again, you have to rely on your provider, right, your injector, and have an honest conversation and go slow.
To use good judgment too, yeah.
Absolutely.
I think too often There are people who are perhaps afraid of surgery or maybe in need of surgical intervention but don't want to go that direction, and so they try to do too much with injectables. And that's when we can get the really unnatural looking face. I do want to take just a little side tack here. You just mentioned filler that is not permanent versus filler that is more permanent. Could you just discuss the benefits of something that is not permanent, even though someone might hear this and think, well, why wouldn't I want it to last? But what are your thoughts about that?
Yeah, well, a couple things. Number one, especially if you're embarking in this industry and you're a patient new to the field, going slow and utilizing products that potentially can be reversed or dissolved if you're not happy is certainly advantageous. It's a lot easier to add than subtract when it comes to volume in the face, particularly with products that you could dissolve if you'd like to. It allows you kind of a preview of what something more permanent might look like, whether that's fat or other products that are permanent. And it allows the ability, again, for the injector, if you're not happy or if maybe you have a problem or an unwanted result or complication, now you can get rid of that product. And a lot of the fillers are hyaluronic acid derived, which is a naturally occurring compound in our body. And so our body just slowly dissolves it over time. Mm-hmm. So I think that hyaluronic acid and non-permanent fillers are an excellent way to start. And again, done tastefully can really make a lot of beautiful changes in patients before they're starting to see the more dramatic changes with age. And there certainly is a balancing point. And that's what I tell my patients. In the end, there's no shortcut in the face. Anywhere in the body, there's no shortcut, but particularly the face. The one thing you wear 24/7, 365 that is always visible is your face. So if you're investing in aesthetic treatments, that should be a primary investment for you, and you want to make sure that you're fully committed to what you're having done and you trust the person doing it for you.
Mm-hmm. That's great information. And what about the possibility of, with time and with age, a permanent filler now being in a slightly different position as things shift and as the face ages? What do you think about that, or what have you said to patients about that?
Yeah, I'm pretty cautious when it comes to permanent filler outside of autologous fat grafting. Mm-hmm. I really believe that dissolvable products are advantageous when it comes to filling. Permanent products have to be very carefully selected. And you're absolutely right. Those things can change with time. Your facial architecture will change with time. And so maybe where that product is placed now, as your body changes, may not be ideal as you get 4 or 5, 10 years down the line.
Exactly.
So I don't use a lot of permanent fillers in my practice aside from autologous fat grafting currently.
Fair enough. Well, let's talk about surgery now. So how can you tell when someone needs surgery for facial rejuvenation? How can you tell what could be treated surgically, what could be treated non-surgically? So when do you need a facelift, neck lift, or eyelid surgery?
That's a great question. And I'll begin by saying that the term facelift, it seems to intimidate a lot of patients because they think of people having these full facial rejuvenations and, blown up like a balloon postoperatively and very prolonged recovery. A lot of that has changed very much, especially in the past 2 decades as we look at recovery from facelift operations or eyelid operations. What it comes down to is, again, the anatomy. I simply put a mirror in front of the patient and we take our time, we start from top to bottom, we talk about what's bothering them. So if you and I do that right now, if we talk about the upper third of the face, most of that is related to muscular movement, right? Mm-hmm. So neurotoxins can really take care of a lot of the upper third of the face problems.
Yeah, just an injection, yeah.
Just an injection. Brow lifting is a procedure. You got to be careful with brow lifting. It has to be the right person. If you look at quote-unquote attractive people, whether they're on a cover of a magazine or they're a Victoria's Secret model or an actress or an actor, not a lot of people have high brows. They have aesthetically full and attractive brows. So I'm cautious with who I do brow lifting on. Sometimes it's indicated, but that's really the only primary cosmetic procedure that occurs in the upper third of the face. Mm-hmm. When we get to the middle third of the face, now you're dealing with, aside from the nose, which is really a separate topic altogether,
sure.
You have your cheeks and you have your periocular or your eyelid region. Mm-hmm. And the eyelid region is one of the areas where we start to get clued in to that anatomical aging changes. Mm-hmm. And it simply manifests as heaviness of the upper eyelid skin, and then puffiness of the lower eyelids that tends to be fat that's pushing out over the orbital bone. Mm-hmm. A lot of people think that lower eyelid bags are related to lack of sleep or diet or other habits. And although that may contribute slightly, it truly is an anatomical problem. And once they're there, they're really not going to go away unless they're removed.
Right.
And so people tend to chase that with trying to camouflage it with fillers and other devices and things like that. And that may buy them some time. They might get a mild change. But one of the most impactful procedures that I can do for a patient that literally takes me, in most cases, less than an hour, maybe 30 minutes, is removing fat pads from the lower eyelids and trimming the upper eyelid skin. It's amazing how that can rejuvenate and reverse the clock in patients. And they always say the eyes are the window to the soul, right? And so if you feel and look tired in the mirror, if we can fix that for you in a 60-minute period, that has a significant impact for a lot of patients in their confidence level and the way they approach their social circles. And then in the mid-face, which is the cheek area, over by the central part of the face where your cheek is, that's a volume issue primarily. But as you move back towards the ear and down towards the jowl, that is where face lifting now comes into play, because now gravity has taken over. Right? We don't live on the moon. We're all subject to gravity, and Father Time always wins.
Oh, yes.
Right? And so it becomes an issue of at what point in time do we intervene? And that's when we start to see jowling that has moved beyond the border of the jawline, so you can't really hide it with fillers or other products. Remember that injectable products don't truly lift, okay? They add volume to change the shadow, so it's an optical illusion of a lift. But in the end, a true lift requires anatomical change and lifting of the jowl and the neckline. And so
that's a great point.
When you start to see that, then that's when we have the discussion. And patients have to recognize, again, if you're going to use your hard-earned time and money and invest in something, you want to invest in the right thing. And at some point in time, a surgical operation by far is the most straightforward, best use, and most predictable result you can ask for when you're investing in your face.
Great. And what about neck?
Yeah, so neck, honestly, a lot of patients come in for their neck before their jowls. You know, we see a lot of changes in the neck that can bother patients very early on. They get the sagginess, maybe they have fullness of the fat. They get two lines that run down the center of their neck, which is related to laxity of the neck muscle. And the neck is primarily surgical. You know, a lot of the modalities out there that are non-surgical have a variety of pros and cons. And in some patients, chasing a non-surgical neck result could A, lead to unsatisfactory results, or even B, make our job even harder when we go back in there to actually try and treat the neck with the more straightforward operation. So I'm very cautious with non-surgical modalities in the neck, and the neck can be very unforgiving because the skin is thin, and so you really got to make sure that whatever you're doing is going to create a very pleasing contour for that patient.
Yeah, I think that's great information for patients that depending upon the area of the face, surgery might be the go-to as opposed to non-surgical treatments, whether they're topical or injectable, et cetera. So that's very helpful, I think, for listeners. So we've talked about some of the basic components of things that can be done to rejuvenate the face. Let's talk about combining therapies. What are the benefits and potential pitfalls of combining therapies and treatment modalities? And I would love to start, of course, with the benefits. What do we gain by combining things, whether we do it at the exact same time, the same setting, or we stage it, meaning we would come back and then do that second part?
It's a great point. I love combination procedures, especially when it comes to treating, again, the pillow and the pillowcase, right? So let's call the pillow the deep tissues of the face that sag and have jowling and fluctuate with gravitational change, kind of like tectonic plates change, on our Earth's planet.
That's right.
It's just how it happens. And so I routinely not only combine modalities, but combine areas. So I would say that at least 80%, if not more, of my facial aesthetic surgical cases, if I'm treating the face, I'm treating the eyes at the same time. I can certainly isolate those for patients, but what I find is if we make the eyes look 10 years younger and not the lower face, then they perseverate over that and come back and have the second operation done, right? That's not always the case, but...
Yeah. And are you treating the eyes surgically or chemical peel? Or?
Good question. So both. So, my most common procedure, if indicated, would be doing a lower face and neck lift, taking out the upper eyelid skin, taking out the lower eyelid fat. But I'm very cautious about the lower eyelid skin. And as a matter of fact, the deep chemical peel that I do really treats the lower eyelid skin very well. I rarely, and I mean this, rarely take skin out of the lower lid. if you do that, it might be indicated in certain people, but then things can happen. You got to adjust the corner of the eyelid.
Yeah.
You run the risk of changing the shape of their eye. And a lot of times it's not necessarily skin laxity, it's just skin texture and pigment change. So I will routinely do at least a lower eyelid chemical peel and a perioral, meaning around the mouth, to treat the vertical lines at the same time as a facelift and an eyelid operation. And I find that incredibly impactful. I also will often do what's called a central face peel. So the areas where I lift up the skin to expose the deeper tissues, which is back by the ear, that's called undermined skin. I won't deep peel that at the same time, but I will do the central face so that they get a almost complete facial correction. And then we simply come back and touch up the cheeks at a later date. For those who get to my Instagram, you'll see some people on there where we show you the progression of the combination of facelift, eyelids, and the deep chemical peel. That can work phenomenally.
That's nice.
And the final touch would be fat grafting if needed in certain areas.
Let me just add a quick question in there because I think this is important for the listeners. A lot of people, when they think of facelift and we're kind of lifting the skin up from the side and then repositioning, et cetera, a lot of people have a misunderstanding of how far you're going, basically. You're talking about doing a central facial peel and not applying the chemical peel to the skin that's been undermined or lifted. But tell us how far you make that dissection, or what is the distinction there?
That's a great point. There's been a lot of publicity over the past couple of years about this terminology called a deep plane facelift. And, competitors of mine in the industry and people out there are trying to act as if this operation is a new procedure. And it's truly not. It's been around almost 70 years. And
Yes.
Anatomical concepts are not new. I think marketing creativity is fine, and I think everyone should be able to market how they believe their technique creates the aesthetic result that they want, but the primary principles have not changed. As a matter of fact, if they change as often as they do on Instagram, it'd be scary, I think, to have that
That's
operation.
a good point. Absolutely.
So again, I think you got to be careful what you digest off of social media. But getting back to the concept, when it comes to face-off operation, there's two layers that we have to treat. There's the skin layer, and then, of course, the deeper layer that we mentioned. And a term that gets thrown around, but I always tell my patients this term because it's important, is an acronym called the SMAS, S-M-A-S. And that stands for Superficial Musculoaponeurotic System. The only point is that is the bedsheet that wraps around the facial muscles and fat. So the jowls and the sagginess are in that layer.
It's like that gristle tissue on the muscles, but under the skin. Yeah.
Yes. And in my opinion, you need to lift the skin and the SMAS together as a unit to truly get a change. Skin can be unreliable. If you only tug on the skin, remember, this is a living organ. So it recycles itself, let's say every 6 weeks, give or take. And so this living organ is going to be undergoing life cycles. And if you just tug on the skin, there's a potential that, early on in your recovery phase, let's call it 3 months, 6 months, maybe a year, that skin might relapse. And if we haven't treated the deeper tissue layer, we may not have the result that we hope for.
Yeah, just stretch back out.
Yes. And so, but on the same token, for those of us who do a high volume of facelift surgery, we are risk averse. And so by no means do I want to create a complication. And as a matter of fact, the two options once you treat the SMAS is to pitch it together, called application, or to actually lift the SMAS as a very precise layer itself and then move the skin and SMAS together. But we do that by avoiding facial nerve branches. So we're not dissecting all the way to the corner of the mouth to try and pull the mouth up or create a Joker look. Absolutely not. I tell my patients, I want you to look restored, not different. I'm not trying to change the way that you look.
Yeah, I think a lot of people don't understand that, so I think that's great that you're explaining it.
It's a perfect point. This is our day-to-day job. If we were chasing down the nerve and putting it at risk, I'm not sure our longevity in practice would be very long.
That's right.
So
That's right. Well, that brings me to my next question. Given what we know about potential complications of each of those categories of facial treatment, are there risks sometimes of combining treatments, especially if they're done in the same setting?
There certainly can be. As I mentioned, I won't peel over the areas where I lift up the skin. Now, that's partly because my peel is deep. It's arguably the deepest peel that exists. And it's not my peel. I learned it from my mentors. But the formulas I utilize go very deep.
So let me just go into that a little bit further. So if you were to put a chemical peel on top of skin that had been elevated and operated underneath, then you're affecting the skin on both sides, underneath it and on top of it. And what could happen in that situation? What could be the worst thing that might happen?
Well, again, these are all hypotheticals because it depends on the surgeon and their technique and what they're using.
Of course.
But yes, suboptimally, if you will, you could have skin necrosis, which means the skin can slough and potentially die and have to heal as a wound.
Yeah.
You could have pigmentation issues, either hypo, meaning lack of pigment, or hyper, too much pigment, and scarring and asymmetry. Those are all potential risks if combined with just not the right depth and operation.
Yeah. Great point. And I think that's very educational for the listeners. Well, given that, how do we safely combine interventions and treatment? What things do you think about when you are planning your combined treatment regimen for patients?
Well, a couple components. I think procedure preparation is very important. You know, the operation is just one event, but what you do leading up to the operation and what you do after the operation can be equally as important. I also tell patients that, we can do as much as we can in one setting, give ourselves 100% in that surgery and hope for the most perfect result, but recognize that revisions may be required and to be prepared for them if the time comes. Again, I want my patients to be very proud of the result, and they are a reflection of my work. And so we take it very seriously,
True.
as we hope all surgeons do.
Your calling card.
Right.
Yeah.
And the other thing is, as a surgeon, the area that is primarily non-surgical is around the mouth. And so I tell patients ahead of time, unless we do a chemical peel or a very rare lip lift, the corners of your mouth, the marionette folds, those areas are still going to need additional treatment with filler, good skincare, maybe even a repeat resurfacing. So I prep patients for that ahead of time. I say, hey, listen, I'm a surgeon, not a salesman. And so I want to level with you. I would like to underpromise and overdeliver, but here are the things we have to do ahead of time, and here's what involves recovery. I think proper skin preparation for the chemical peel is really critical, and I think optimal nutrition prior to surgery is important as well.
Yes.
So in my practice, all my patients get offered pre and post vitamins as part of our surgical pack to optimize them, whether it's a face or a body case. We closely examine their other vital organs, make sure they don't have big issues with their heart or lungs and things like that. We monitor what they're on for their skincare, and we try to give them, prepare them the best for success pre-surgically, and then afterwards we're very hands-on post-surgically to really ensure things heal well.
I think that's a great philosophy. A surgeon, you're not just treating the patient in the operating room, you're treating the whole patient, and that encompasses before surgery and after surgery. I think that's wonderful. Well, you touched on this just a little bit, but is there a time limit for how much to do at once? If somebody wants everything done, do you say this is how much is safe to do based on time and perhaps the type of anesthesia? What anesthesia would you use if you were having to spend a long time with a patient in the surgical setting?
It's an excellent question, and you might get different answers based on who you talk to. So you're just going to get my opinion on these topics, but recognize that opinions may differ, and that's okay. Typically, I try to keep my surgeries 6 hours or less. That tends to be kind of the standard in an outpatient setting. That may vary, and there may be some surgeons who think you can go longer and it doesn't increase the risk profile, but I would say a lot of the standard guidelines that I've been exposed to, that I've researched, and for those that I work with, we try to keep it 6 hours or less. And that is a very safe window in the majority of cases. And remember, general anesthesia has changed so much in the recent times, where there's a lot less of inhalational gas anesthesia and much more IV sedation based, for example, propofol, kind of like having a colonoscopy. And we take a lot of pride at our surgery center here in Kansas City to focus on IV sedation based anesthesia that may still involve some form of either an LMA or endotracheal tube for airway securement, but we're not trying to quote unquote snow our patients, right? We're trying to get them nice and calm and comfortable, get them off to sleep, monitor their vital signs, and wake them up efficiently, and make sure they're happy when they get up, as far as they feel that they're not nauseous and they feel that they can come with it. And so we take that very seriously. Everyone recovers differently, but we do a lot of small little detail things to help with that.
That's great.
As far as procedure combination, I tend to separate the face and the body if I can. So I can do a full face case in less than 6 hours, and that would include brows, eyes, face and neck lift, and a deep peel. just like I can do a full mommy, typically meaning a breast to organ lift, tummy tuck, lipo, and maybe one additional area depending on time. Occasionally, if I isolate the face case to just a facelift or just eyes or just a peel, then we can add a body case of some type. So it's procedure specific, but I want to encourage patients to not be scared of general anesthesia. If having local anesthesia or oral sedation in the office can be as concerning or quote unquote risky, or even more so in some cases, depending on, again, who you talk to and what's being used. I love the idea of local anesthesia and oral sedation in the right settings.
Local anesthesia just means you've injected some numbing medicine.
Right. And then some use oral medications to calm the patients or relax them. But that has its own risks. And so if you chase that avenue, make sure you ask your provider about those risks and just be aware of what they are. When it comes to an operation like a facelift or mommy makeover case where you're placing implants, there's really nothing better, in my opinion, than a negative pressure, humidity-controlled, sterile operating room. It really is one of, if not the safest place you can have something, this important and intimate to your body being done in the safest manner possible. So again, that's my personal opinion, but that's how we take care of most of our patients, because I want complete control of their vital signs in their airway. I want to minimize any infection risk, and again, try and create a very safe, smooth operation for them.
So you're primarily working in a surgery center situation rather than an office procedure room or something like
Primarily. I will do certain things in the office, but I'm particular on what I do, and I explain why I do and do not do them when I do the consult.
Well, are there some additional things you can do to help our tissues tolerate some of these combined procedures? Are there topical things or injectable things or light treatments, etc.? What do you tend to utilize to try to decrease risk of complication and improve the healing of those combined procedures?
Well, it's an excellent point. I think we've touched on some of those things already. I do believe in vitamin nutrition, optimizing them nutritionally. I believe postoperative counseling is very important. So if you're having a tummy tuck, making sure that you have everything you need at home when you're done with the operation. I don't want the spouses skirmishing for all these things the day of surgery. So when you come into our practice, we do a 1-hour preoperative evaluation with the patient. We pre-prescribe all their medications. I'm a big believer in non-narcotic pain medication management, and that's a big component of recovery.
Yeah.
And so we do a scheduled non-narcotic pain regimen with pain medication as needed, provided. And then one of my really key components, at least for me, is scar care and management. Patients, whether it's a breast lift or a facelift, the scars are incredibly important, and patients are very sensitive to scar and scar healing. And sometimes that can be a barrier for patients to having the operation done. But I try to show them long-term results of scar healing and explain to them that the day of surgery, we're going to do everything we can to make the scar look as beautiful as possible. But then we are on a journey together over the next 12 weeks to nurse that scar back to health.
Yeah, that's great.
When it comes to scar healing, you need moisture, you need compression, you need massage, and you need delicate care. When we were kids, and you know this, as a retired plastic surgeon, moisture is so important. When we were kids, we were taught that if we scrape our knee, let it scab over. That was the wrong answer, right?
That's right.
That was the body's response to creating a moist environment. So we're very neurotic about scar care in the body and the face. And as a facelift surgeon and a body surgeon, I think your scars tell a lot about your attention to detail and, again, the postoperative regimen.
Is there anything else you do to the tissues themselves to try to accelerate healing? Do you do LED light treatments or anything like that? Or
Yeah, so I run kind of a lean, simple practice. I'm primarily surgical with injectables and resurfacing with chemical peeling, but I have a great relationship with several other aesthetic establishments in Kansas City where I send them for such therapies.
Ah, yes.
I think maintenance post-care is important. There's a lot of hot topics out there. One of them is hyperbaric oxygen therapy. I have not been convinced that in a standard facelift operation, hyperbarics adds a whole lot to the care. I think it's kind of a, this is a neat opportunity. But remember, hyperbarics only works when you're in the tank. It has its own risk, and it does have a price component to it. Yeah. And again, a properly elevated skin flap with appropriate treatment should do well living in a standard oxygen environment. Not to say you shouldn't do it, but again, I take my patients' finances seriously, and I want to make sure they're investing with their hard-earned money efficiently, smartly, and effectively, if that makes sense.
It does.
I love laser therapy of all kinds. I think red light therapy has gained popularity with us. I also believe exosomes are very nice for topical treatments. So I have added those to my regimen on all my patients for facial aesthetic procedures.
Yeah, we did an episode all about that. It was very interesting. Yeah.
Yeah, it's another finishing touch that can really help recruit. Again, we're utilizing technology. It's kind of like having an iPhone versus a Razr Motorola, right? Or the old car phones of the day.
Right.
Technology in this industry is fast moving, but a lot of it, if well thought out, can be incredibly helpful to enhance your result post-surgically and to maintain it as well.
Yeah, that's great. And you did mention fat grafting. Would you mind just explaining what that is and what kind of impact does it have, whether the outcome or recovery in terms of combining procedures and treating safely? Are there concerns? What are your thoughts?
It's a good question. So fat grafting has undergone a large pendulum shift, I would say, over the past couple of years. There was a component where I think everyone was fat grafting a lot at high volumes. And then as patients aged, in some instances, that fat grew with the patient or it created maybe a look the patient wasn't desiring. And that's not everybody, okay? That's just one component of it. I tend to be more conservative when it comes to fat grafting. Like I told you, it's always easier to add than subtract. In the Midwest market, people want a more natural look. We're not looking for a very aggressive look. There's a surgeon who I respect who says fat grafting at times can take a good procedure and make it a great procedure. And I think that's true in certain instances. Mm-hmm. For me, fat grafting has to be indicated with a true volume loss. So, if I look at my before and afters critically and I go through it with my patients, what we're doing in a facelift is restoring volume that they already have. Mm-hmm. So if I'm going to add additional volume that they didn't previously have, I got to make sure I'm doing it in the right place for the right reasons.
That's
and
a great
so
point.
I'm very selective on who I do it on, and you can always add more volume down the line. Fat grafting can easily be done as an outpatient procedure in the office, no doubt. And so I'm looking for areas of volume deficiency. So the most common areas I will fat graft, if indicated in patients, is going to be in the cheeks, the chin and pre-jowl, the temple, and potentially the lips. Those are areas where we may add volume as an adjunct to a surgical procedure. And again, you're going to get different opinions, but I'm conservative with my fat grafting for sure.
Mm-hmm. And I think some listeners know this already, but some may not. How do you get the fat that you are placing into the face?
Good question. So you're harvesting from yourself. In other words, autologous means fat from your body. Mm-hmm. There are products out there that have shown they can potentially stimulate fat growth when injected, but that's a different component. And in this case, usually I take it from either the medial thigh, the abdomen, or the hip through liposuction. And then we do certain things with the fat once we've harvested it to really isolate the cells that are going to create a very nice response for you and avoid some other problems like oil cysts and things like that. You want to have a very nice, clean, titrated, and filtered fat grafting once you inject it. But those are the primary donor sites, are the areas I mentioned.
Do you think that some of the qualities of the fat, the person's own fat injected near or under the skin, will change some of the qualities of the skin? Do you think there's a little stem cell effect or anything like that?
Sure. There's a lot of chatter around that concept. And I do believe, we've proven that there is a component to that. And that may depend on the depth of the injection, mm-hmm. how much you process the fat. So there's been some great studies that show, the more you filter it down to even where it's no longer a particle size, it's more of just a liquid foam, if you will, can be utilized. So there is certainly a regenerative component to the fat grafting, but there's a lot of detail that goes into that depending on how it's harvested and how it's injected.
Yeah. Well, I'm curious if you have any patient stories that might illustrate the benefits of combining treatments to achieve a goal of facial rejuvenation. How much happier do you think patients are with results from combined treatments?
Mm-hmm. Several can come to mind.
Oh,
what I love is when patients come in and they've got an event coming up. It's a family reunion, it's a wedding, maybe it's their wedding or it's their child's wedding or some life event that they're preparing for. Nothing makes me happier than getting a selfie from that patient at that event after their surgery and seeing how happy they are.
Oh, that's got to be great.
I truly love my job. I spent a lot of time in training and a lot of effort. For example, my fellowship, I lived away from my wife and kid for a year to get that training. And I did that with the end goal of making sure I could bring the best possible version of me every day to my career and my work. and I just love doing what I do. And I don't do any operations I don't love, because if I don't love them, I don't think I'll be the best at them.
Fair enough.
And so I've really narrowed down to the surgeries that I love. And now getting to that, I had a patient who was going to a high school reunion, and she had gone through some life changes and had worked really hard on some weight loss. And again, Father Time had kind of shown some changes to her lower face and neck and her eyelids. And she came in and she had a timeline, and we met the timeline.
Yay.
And we did the operation. We combined the procedures I mentioned, upper and lower eyelids. We did a nice deep chemical peel on her and a lower face and neck lift. And thankfully, everything went smoothly as expected. And then when she went to reunion, she just told me, she's like, it's the best version I felt of myself. I look in the mirror, I look as good as I feel. I hear that a lot from people, is when they look in the mirror, they don't look as good as they feel. But the favorite thing that I hear is, I wish I would have done it sooner.
I love that.
Because you don't want to convince your patients, but authentically I say, hey, listen, I look at you right now and you're already a beautiful person, but I know that things are bothering you. I would love the opportunity to help refresh that for you. And in one day we can do that, right? And then together we recover and off you go. And so that's one of the stories I can think of recently that really brought joy to me.
Oh, that's just wonderful. I love hearing that. Well, gosh, we're getting close to our end here, but are there any future treatment innovations you would love to see as technology progresses? Anything that would facilitate your ability to rejuvenate the face or to combine treatments in that same goal of rejuvenating the face?
Yeah, I'm fortunate that I do a lot with industry. I get the chance to travel and lecture and also be on advisory boards where I kind of see some of the wave of the future. And I think both in body and facial aesthetics, we're going to see a lot of stuff coming down the pike. Mm-hmm. I always tell people, be careful of the shiny new penny. I'm a relatively slow adopter because I'm very methodical in how I assess things. Mm-hmm. But I do think there's going to be some significant stuff brought forward as far as regenerative procedures for patients. But I would caution people on shortcuts. Yeah. You got to be careful in shortcuts, especially in the lower face and neck. So top of mind, we're going to see a lot more with exosomes. We're going to see a lot more with regeneration. And now that we see a lot with weight loss drugs affecting the face in a pan-facial manner, both muscle and fat and skin, I do think biostimulation and other things that come down the line may be helpful in a more comprehensive correction of those patients.
Interesting. Well, we're looking forward to that. Gosh, thank you so much. And I really want to ask you if you have any lasting thoughts for the listeners, whether it's about combining treatments in the goal of facial rejuvenation or about some of the cautions you talked about earlier with following the shiny on social media, or even practitioners out there who kind of bill themselves as, this is the newfangled way to do it and the only way to do it, and I'm the only one who can do it, that kind of thing. Any thoughts you'd like to leave the listeners with?
Sure. Yeah, I think I would just say be cautious in the marketing that you see and be diligent. I think when it comes to trademarking procedures and things like that, especially procedures that have been around a long time, maybe there is a unique component to it. Maybe it's a marketing gimmick. I don't want to be adversarial or call anybody out. I just want to caution the consumer to really do your research. Spend your time with your surgeon in consult, look at the before and afters, ask them about their technique, and then you can truly decide, is this technique really that much different than what someone's doing, down the road, so to speak. And I think being authentic and how we present ourselves and the results that we're trying to obtain and what we can take care of for our patients, that's what I take pride on. And again, for me, I want my results to do the talking. So if you look at my platforms, there's not a lot of me talking. I'm not a big talking head on social media. I'd rather people come to my page and look at results and decide if they like that. Then they can come in and we can have an intimate consult to discuss their needs, and they can decide if I'm the right person for them. So I would just say be cautious out there when it comes to marketing, particularly in facial aesthetics, but really anywhere in the body.
Yeah, I think that's well said. Well, Dr. Chris Surek, you've given our listeners a lot to think about and a lot of great information. Thank you for taking the time and being here. Really enjoyed chatting with you.
Regina, you've done a fantastic job with this podcast. So many impressive episodes. It was truly an honor to be on here. And again, very grateful. Thank you.
Oh, thank you. Take care. Well, that's our show for today. Hope you enjoyed it and learned something too. Don't forget to subscribe, rate, and review. Please share this podcast with someone else who might be interested. And while you're at it, check out the podcast website for related topics to explore. It's www.plasticsurgerydecoded.com. And as always, thank you for listening to Plastic Surgery Decoded.